If you break your arm, you go to the hospital, and you get an X-ray.
Right. Very standard.
Exactly. The image pops up, the doctor points to a jagged white line and says, there it is. It's broken. It is completely binary. You can see the problem, and you can see the solution.
Yeah, you see it, you fix it.
But if you're listening to this right now and you've ever dealt with something like recurrent pregnancy loss or, the really intense chronic tissue pain that can happen during menopause, you know that the metaphorical X-ray machine is just completely useless.
Oh, totally useless.
Yeah, I mean, in women's health, you're so often just handed a generic estrogen cream
Yeah.
or told to just keep trying and send out the door. The diagnostic landscape has historically been nothing but guesswork.
It's been the absolute definition of diagnostic muddy waters. I mean, for decades, the medical community treated so much of female biology with this really blunt instrument approach.
Right.
Because the underlying cellular systems were viewed as either, too complex to bother unraveling, or, frankly, they just weren't considered a funding priority.
Which is incredibly frustrating. But today, we are pulling apart a stack of new, hard medical data that proves that era of guesswork is finally over.
Thankfully.
Yeah. Welcome to today's deep dive. We are looking at cutting-edge clinical protocols for platelet-rich plasma, a really fascinating new PubMed study on estrogen at the cellular level, and the just-released 2026 guidelines from the American Society for Reproductive Medicine.
It's a great stack of sources today.
It really is. And the common thread weaving through all of these sources is this massive shift away from generalized symptom management. We are finally moving toward letting the body's own biology and hard genetic evidence dictate the treatment.
Yeah, we're finally entering an era of personalized cellular-level care. It's about understanding the actual mechanisms of healing rather than just throwing therapies at the wall to see what sticks.
Right, exactly. So I want to start at the absolute foundation of that healing, the cellular level. Our first source is a PubMed study looking at a very specific, potent type of estrogen called 17-beta estradiol.
A really crucial hormone.
Yes. And the study looks at how it interacts with cultured human dermal fibroblasts. Now, just to set the baseline, a fibroblast is essentially the worker bee of your tissue.
That's a good way to put it.
It's the cell responsible for building the structural framework, like the collagen and elastin, that keeps tissue strong and flexible.
And historically, the medical consensus has pigeonholed estrogen almost entirely into the reproductive cycle.
Right, like we only think of it regulating periods or pregnancy.
Exactly. But what the study illuminates is the massive systemic role estrogen plays in skin homeostasis and wound healing. I mean, it's a critical modulator for the entire inflammatory response.
Yeah, the researchers actually point out that postmenopausal women, or, well, anybody dealing with a significant estrogen deficiency, experience a demonstrably reduced rate of wound healing.
Which makes sense when you look at the mechanism.
Right. So to figure out why, they set up an in vitro wound healing assay. They basically took a culture of these skin fibroblasts, created a mechanical wound by literally scraping a gap through the middle of the cells, and then introduced the 17-beta estradiol.
And the result was immediate.
It was crazy. The estrogen significantly increased both the migration and the proliferation of those dermal fibroblasts. The cells essentially rushed into the gap to repair the damage.
Because they proved that human dermal fibroblasts are direct estrogen target cells. They actually have specific receptors for it.
Oh, really?
Yeah, so when that estrogen binds to the fibroblast, it enters the cell's nucleus and actively alters gene transcription. It modulates blood vessel creation, inflammatory cells, and the epithelialization of the tissue.
Wait, before we move on, let's clarify that term. The study uses the word epithelialization a lot. Are we just talking about skin cells knitting themselves back together to close a wound?
Essentially, yes. The epithelium is the protective outer layer of cells. So epithelialization is just the biological process where those cells multiply and migrate across a wound bed to seal it off.
To prevent infection and stuff.
Right, to protect it from the outside world. And estrogen acts as the catalyst for that migration.
So estrogen is basically the ultimate construction site project manager. A storm hits the site, which is the wound, and the project manager grabs a megaphone, binds to the workers, and tells them to multiply and migrate to seal up the damage.
That is a highly accurate way to visualize the mechanism, yeah.
Hold on, though. I'm looking at the data regarding a specific protein called TGF-beta-1, and it doesn't make any sense to me.
Okay, let's break it down.
So the study says TGF-beta-1 is a protein that promotes cell growth and collagen production, right?
Right, correct.
Well, the researchers found that when they gave estrogen to healthy, unwounded cells, the cells pumped out more of this growth protein. But paradoxically, when they gave estrogen to the cells that had actually been wounded, the estrogen decreased the secretion of TGF-beta1.
Yep.
If this protein helps cells grow, why would estrogen decrease it right where the wound is? Shouldn't the project manager be pumping out as much of that growth protein as possible to fix the cut?
I mean, it seems completely counterintuitive if you look at it as a simple on-off switch.
Right, like volume up or volume down.
Exactly.
Got it.
But this paradox actually reveals the sheer brilliance of the body's localized feedback loops. Estrogen doesn't just yell build, it reads the room.
What do you mean it reads the room?
Well, in unwounded intact tissue, estrogen increases TGF-beta1 to promote normal, healthy cellular turnover. It keeps the tissue thick, elastic, and strong.
Okay.
But at the site of an acute mechanical wound, the environment is already flooded with inflammatory signals.
Oh, I see.
Yeah, so if you add too much TGF-beta1 into that chaotic environment, it triggers runaway inflammation and an overproduction of really dense, disorganized collagen.
Which would result in a massive, thick scar.
Precisely. So the estrogen steps in and downregulates the protein at the wound site. It's essentially saying, heal the gap, but do it cleanly, don't overdo it, and create fibrous scar tissue.
Wow.
Yeah, understanding this highly localized, context-dependent mechanism is what is driving the entire future of regenerative medicine right now.
That is wild. It isn't just a volume dial, it's an intelligent mixer.
Exactly.
And seeing how the body uses estrogen to choreograph healing is actually the perfect setup for our next sources, which look at how real-world clinics are applying this exact cellular science today.
Yes, moving from the petri dish to the clinic.
Right. We were seeing a revolution in treatments for genitourinary syndrome of menopause, or GSM, and vaginal atrophy.
And we really have to emphasize that this is a profound quality of life issue.
Absolutely.
As estrogen levels drop during menopause, the vaginal tissue loses that project manager you mentioned. The collagen degrades, the tissue thins out, and millions of women suffer from severe dryness, chronic irritation, and incredibly painful intercourse.
And according to the clinical protocols we reviewed from the Women's Health Clinic, the modern approach is no longer just handing a patient a single cream. They are actively layering multiple therapies.
Yeah, the multimodality approach.
They are combining energy-based treatments like vaginal lasers or radiofrequency with topical moisturizers, vaginal estrogen, and platelet-rich plasma.
The clinical strategy here completely abandons the old either-or mentality. They are sequencing these interventions to target complementary biological pathways rather than just hoping one mechanism fixes everything.
Think of your skincare routine, right? You wouldn't just use a harsh exfoliating acid, wash your face, and then go out into the sun without moisturizer or sunscreen.
No, you'd ruin your skin.
Right, you layer products because they perform different complementary tasks. But I do have to ask, is throwing all of this medical intervention at delicate vaginal tissue safe? I mean, doesn't a thick estrogen cream physically block a laser?
That's a great question.
If you do all of this at once, couldn't you damage the tissue? Like over-fertilizing a lawn?
That is a very common and valid concern for patients. But this is where the sequence is critical. It isn't throwing things at the wall. It is a highly choreographed protocol designed around the laws of physics.
Right. The clinics explicitly state you do not use the creams on the morning of a laser procedure. You have to space it out.
Let's look at the mechanism of a vaginal laser. The laser works by delivering thermal energy to create microscopic, controlled injuries in the tissue.
Like the mechanical scrape in the study.
Exactly. This trauma triggers the inflammatory cascade we just talked about, forcing the fibroblasts to initiate neocollagenesis, which is the laying down of brand new collagen fibers.
Okay.
But energy-based lasers are attracted to water. They target the water inside the cells to generate that heat.
Oh, that makes perfect sense. It's like trying to boil an empty pot of water. If the laser is looking for cellular hydration to heat up, and the tissue is severely atrophic and bone dry, there's no water there. You're just damaging the pot.
That is an excellent analogy, and it is the foundation of what the sources call the wet tissue rule. If a clinic just applies a laser to dry atrophic tissue, the treatment is highly ineffective and potentially really uncomfortable.
So what's the fix?
They prescribe vaginal estrogen for 2 to 4 weeks before the first laser session. The estrogen enters the nucleus of those cells, thickens the epithelium, normalizes the pH, and crucially, hydrates the tissue from the inside out.
It primes the canvas.
Precisely.
It fills the cells with water so the laser hits its target perfectly. Then, after the laser creates those microchannels, you apply moisturizers to soothe the surface while the deeper structural integrity rebuilds.
Yes.
And finally, adding platelet-rich plasma, or PRP, delivers a massive, concentrated flood of growth factors directly into those open microchannels to dramatically accelerate the entire healing process.
Which brings us to the science of PRP itself, which is essentially harnessing the patient's own internal biological pharmacy.
It sounds like science fiction, but the procedure is remarkably fast. If someone goes in for an O-shot, which is a specific regenerative injection for intimate health, they do a simple blood draw from the patient's arm.
Just like a routine physical.
Exactly. They put that blood into a centrifuge and spin it rapidly to separate the red blood cells from the golden, platelet-rich serum. Then, they take your own concentrated platelets and inject them back into the numbed vaginal tissue in the clitoris.
The platelets are the key here. They aren't just floating debris. They are sophisticated biological messengers. When they are activated and injected into tissue, they release at least 8 specific growth factors.
So PRP is essentially acting like a biological flare gun. You inject the serum, the platelets fire off these growth factors, and that signals the body to start rebuilding.
Right.
How exactly does that work at a cellular level, though?
Well, those growth factors physically lock onto the receptors of local stem cells, signaling them to migrate to the area and differentiate into whatever tissue is needed. And crucially, they trigger a process called angiogenesis. The growth factors stimulate the endothelial cells to form complex, brand new networks of blood vessels.
And new blood vessels mean massive increases in blood flow and oxygen to the area.
Yes.
The clinical sources note that because of this, patients report significant increases in sexual sensation, stronger orgasms, and the regeneration actually reinforces the urethral wall, helping tremendously with stress urinary incontinence.
It's life-changing for a lot of women.
And the results can last 14 to 18 months. But, I mean, when people hear about vaginal lasers or injections near the clitoris, the immediate reaction is usually fear of severe pain.
Oh, absolutely. The thought alone makes you tense up.
But the pain management technology has completely transformed alongside these treatments, right? We reviewed clinical footage of a doctor performing an intense pulsed light, or IPL, laser treatment.
Yeah, that video was remarkable.
Alongside standard numbing cream, they use a device called the Zimmer Cryo 6. It continuously blasts a stream of freezing cryogenic air directly onto the treatment area right as the laser fires.
And the patient is just chilling.
Literally. The patient in the video is completely relaxed, stating she feels absolutely no pain, just a pleasant cooling sensation. The cryotherapy blunts the nerve response so effectively that it makes these procedures highly tolerable.
Which is vital because the applications for PRP are expanding beyond just sexual wellness and into treating incredibly painful chronic inflammatory conditions. A major focus right now is vulvar lichen sclerosis, or VLS.
VLS is brutal. It's a chronic, progressive autoimmune condition that causes severe itching, pain, tearing. Eventually, the architecture of the vulva can permanently scar and fuse together.
Traditionally, the only frontline treatment has been ultra-high-potency topical corticosteroids like clobetasol.
Just massive immune suppression.
Right. Steroids work by broadly suppressing the entire local immune response to stop the inflammation. But they don't actively regenerate tissue, and long-term use on delicate skin can cause its own thinning and side effects.
Our sources highlight an ongoing clinical trial called VULIS-3T, which is actively comparing PRP injections against those traditional steroid creams to see if PRP can become a safe first-line treatment.
It's a steroid-sparing alternative.
And looking at broader clinical overviews, pilot studies show PRP is already significantly relieving the itching and pain and restoring skin elasticity for these patients.
Because PRP tackles the problem from a different angle entirely. Instead of just suppressing the immune system like a steroid, the PRP's growth factors actively remodel the fibrotic scar tissue and promote healthy cellular turnover.
Right.
And because it is your own spun blood, the risk of an allergic or immunologic reaction is practically zero.
It sounds incredible. But I want to play devil's advocate here for a second. With all these clinics reporting wow effects, curing incontinence, reversing autoimmune scarring, boosting sensation, is this just a guaranteed magic bullet?
I'm glad you asked that.
Like if someone walks into a clinic tomorrow, are they guaranteed this miraculous result?
No, and it is so important to temper the marketing with clinical reality.
Yep.
While clinics report that roughly 50% of women experience instantaneous improvement from procedures like the O-shot, the actual outcomes are highly variable. PRP relies on your body's existing cellular machinery.
Right, it's your own blood.
If a patient is older, has complex underlying medical conditions, or is severely hormonally depleted, their platelets and stem cells might not mount as robust a response.
It depends entirely on the raw materials you bring to the table.
Exactly. And regarding lichen sclerosis, while the pilot data is incredibly promising, we have to acknowledge that long-term safety data and highly standardized protocols, like the exact centrifuge speed, dosing, and number of required sessions, are still evolving.
So it's not a total replacement yet.
The medical consensus treats PRP as a brilliant adjunct therapy. It is an amazing tool to add to the regimen, but it is not a standalone magic wand that replaces all proven medical therapies overnight.
Makes sense. Now, we've spent this whole time talking about how adding things, layering estrogen, lasers, and PRP can prompt the body to heal. But what if the hardest, most vital lesson in women's health right now is learning when to stop intervening and instead listen to the body's genetic boundaries?
A very necessary pivot.
Let's look at the newly released 2026 guidelines from the American Society for Reproductive Medicine, focusing on recurrent pregnancy loss.
This is an incredibly difficult, emotionally devastating landscape for couples, and the ASRM's 2026 guidelines represent a monumental effort to bring evidence-based clarity to a field that has historically been plagued by very expensive, unproven interventions.
To establish the baseline, the ASRM now officially defines recurrent pregnancy loss, or RPL, as the spontaneous loss of 2 or more pregnancies, which includes biochemical pregnancies. But the data driving their entire new testing algorithm is really sobering. 50 to 60% of all first trimester miscarriages are due to embryonic aneuploidy,
Meaning chromosomal abnormalities. Random, non-viable genetic errors that occur during early cell division.
Because of that massive statistic, the new ASRM guidelines strongly recommend that the very first step, before anything else, is to perform array-based chromosome testing of the miscarriage tissue itself.
Yes.
They specifically note using advanced molecular microarrays instead of traditional karyotyping. What's the difference between those two tests?
Well, traditional karyotyping is essentially looking at a map of the globe to see if a country is missing. You look at the whole chromosome under a microscope to see if it looks structurally intact.
Okay, pretty high level.
Right. But a chromosomal microarray is like using Google Earth to zoom right down to the specific street address. It uses tiny molecular probes to detect microscopic extra or missing segments of DNA, called copy number variants, that a traditional microscope would completely miss.
So find out the exact genetic why of the loss before you do anything else. But this leads me to a major question.
Sure.
In our earlier sections, we talked about all the benefits of regenerative treatments. But when you read these new RPL guidelines, they actively recommend against adding so many popular treatments.
Yes, they do.
They say no to routine immune testing. They say no to routine screening for inherited thrombophilia or blood clotting disorders. They even state that using IVF with PGT-A, which is pre-implantation genetic testing of the embryo, doesn't actually improve live birth rates for unexplained RPL. Why the sudden shift away from intervention?
If we look at the core philosophy of evidence-based medicine, it is about avoiding harm.
Right.
In regenerative tissue therapy, we have clear, localized evidence that applying a laser stimulates collagen. But in recurrent pregnancy loss, if a doctor skips testing the genetic tissue and jumps straight into empirical treatments, meaning treatments prescribed based on a guess, without a confirmed diagnosis, they run a massive risk.
A risk of putting the patient through unnecessary trauma.
Exactly. If the miscarriage was simply a sporadic genetic error, which is the case over half the time, then putting a grieving mother on daily, painful, blood-thinning injections or complex, expensive, immune-suppressing therapies does absolutely nothing to prevent the next loss.
Because it was just a random error.
It doesn't fix a chromosomal missing link. It merely subjects her to physical risk, financial drain, and immense psychological stress for zero biological benefit.
If the engine of your car broke because a random bolt snapped in half, changing the oil isn't going to fix it. You need to know the cause.
That's right.
But what about the couples where the genetic microarray comes back perfectly normal? What if they fall into the category of unexplained recurrent pregnancy loss?
That is undeniably the most frustrating diagnosis. But even here, the ASRM guidelines highlight a study that reveals something profound about the maternal environment.
Yes, the TLC study. This is fascinating.
It really is.
The guidelines cite an observational study of couples dealing with 3 or more unexplained miscarriages. They divided them into 2 groups. The control group received standard obstetrical care. The other group received what the researchers literally called tender loving care, or TLC.
And we should be very clear about what TLC meant in this clinical setting. It was not a pharmaceutical drug.
Right.
It consisted strictly of psychological support, weekly medical check-ins and ultrasounds for reassurance, and strict instructions to rest and avoid heavy life stress.
The results are staggering. The control group with standard care had a 36% live birth rate. The TLC group, an 85% live birth rate.
Incredible difference.
Simply providing psychological support and stress reduction more than double the chances of carrying a baby to term. How is that biologically possible?
It comes down to the destructive power of cortisol. Chronic psychological stress floods the body with cortisol, which is a glucocorticoid.
And what does that do?
At high levels, cortisol physically constricts the blood vessels in the uterus, restricting vital blood flow and oxygen to the uterine lining.
Wow.
Furthermore, the maternal-fetal interface requires a very specific, delicate immune tolerance to not reject the embryo. High stress shifts the immune system into a hostile, inflammatory state.
Ah, I see.
By providing TLC, the doctors literally lowered the cortisol, dilated the blood vessels, and calmed the immune system, fundamentally altering the physical maternal environment.
It proves that the mind-body connection is not just some wellness buzzword. It is a measurable biological mechanism.
Absolutely.
Treating the mind is sometimes the most powerful evidence-based medicine we have. And that brings us full circle on today's deep dive. We started with estrogen acting as a cellular project manager to heal wounds cleanly.
Right.
We explored how physics and biology intersect when you layer lasers and spun blood to regenerate intimate tissue. And finally, we looked at how relying on hard genetic evidence and the immense power of psychological care is completely reshaping how we navigate pregnancy loss.
In a landscape previously defined by guesswork, understanding the why and the how behind a mechanism is the ultimate tool for patient empowerment.
Yeah.
When you understand how a cellular receptor works or why a microarray is necessary, you are no longer at the mercy of marketing noise. You can advocate for the exact care your body needs.
It takes the mystery out of the murky waters. So, to leave you with a final thought to mull over today, well, I guess we shouldn't use ellipses, so to leave you with a final thought to mull over today, we have spent centuries treating the human body like a broken machine, assuming we always needed to introduce a complex, synthetic chemical to force a repair.
That's been the paradigm, yeah.
But considering that spinning your own blood in a centrifuge can literally regrow a network of healthy blood vessels, and that providing simple psychological reassurance can alter your immune system enough to double the chance of a successful pregnancy. What other incredible healing mechanisms are already hardwired into your biology, just waiting for science to learn how to turn them on?
It's a great question.
Maybe that X-ray machine was never broken. We just needed to realize we weren't looking at a machine at all. We were looking at a living, breathing, highly intelligent ecosystem.
A perfect way to look at it.
Thanks for joining us on this deep dive. We'll see you next time.